And let me introduce today's speaker, Dr. Antonio Adam. He is our second-year fellow, and his topic is psychosis and schizophrenia in childhood and adolescence, new insights and guidelines implementation. Dr. Adam is originally from Haiti. He did his master's and bachelor's in Polytechnic Institute of New York, and then medical school in Dominican Republic. And he did his 2 year of general psychiatry in New York, Richmond University Medical Center. Then he came to us about 2 years ago. And some time ago, I was talking with him, what he was trying to figure out, what will be his academic project. And I thought it would be good for him to talk about psychosis because he had a lot of experience treating psychotic patients in New York. Then I had a little personal experience too with him. I don't know if he knows about this. He saw one patient in emergency room, then I followed this patient. I still see this patient for, she has been coming for 2 years. But one thing he did was he put this patient on a little bit of Risperdal, which usually, we don't recommend or we don't encourage fellows to start medicine, but that was very helpful. And I still remember that patient, and so.
I didn't know that.
Okay.
Okay. Again, my name is Antoine Adam. My topic for today is psychosis and schizophrenia in childhood and adolescence. The first slide of this presentation, I wanted to emphasize the interface of sociology and philosophy with psychiatry. There are two quotes taken from Michel Foucault, doctorate thesis in 1961. I translate from the French, Madness and Unreason, History of Madness in the Classical Age. Michel Foucault is well known for his critical studies of social institutions, psychiatry, medicine, the prison system. In the first quote by Blaise Pascal, this quote is taken from Pascal's most influential theological work, Pensées, translated in English, Thoughts. Pascal said that men are so necessarily mad that not being mad would amount to being mad to another trick that madness played. And there's the other text that was extracted from Foucault, taken from Dostoevsky, the Russian writer, taken from a writer's diary. It is not by locking up one's neighbor that one convinces oneself of one's own good sense. So that's how I wanted to start this presentation. The second slide is an introduction. This is a chronological account of schizophrenia. Schizophrenia, in the various terms that have been used to describe it, madness, insanity, dementia precox, unreason, has been around perhaps since the beginning of mankind. However, it was not until the late 1800s that it was first actively studied. Changes in fundamental diagnostic concepts and their impact on both clinical work and research can be traced back into the 19th century with, for example, Mosley's 1867 description of childhood insanity and Kraplin's description of dementia precox. In 1980, psychosis and schizophrenia gained a renewed interest with the major changes in classification introduced by the DSM-3. It was the year that autistic spectrum disorders were formally separated from schizophrenia. And in 2007, the Child and Adolescent First Episode Psychotic Study, the CAFEPS, by Spaniard investigators Castro Fornieles in 2007, became the largest early onset first episode psychosis sample ever studied and the one with the shortest duration of symptoms and psychopharmacological treatment. The third slide is an outline of my presentation. These are the sections that I'm going to cover. The first section is clinical and diagnostic issues. Under this section, I included definition of psychosis, differential diagnosis, and the diagnostic consideration in childhood-onset schizophrenia. I will also attempt to compare childhood-onset schizophrenia with adult-onset schizophrenia. I will provide some studies that illustrate the premorbid features of childhood-onset schizophrenia. And also, I will mention an overlap with autistic spectrum disorders. I will also talk about schizotypy and schizophrenia in children. I will also make an attempt at etiology, the idiopathic nature of schizophrenia. I will cover the biological correlates, the genetic factors, the monoamine hypothesis, the neurodevelopmental abnormalities, environmental stressors, and also I will mention those controversial hypotheses, the double bind theory, express emotion theory. And towards the end, I will talk about epidemiology, the treatment of child-onset schizophrenia, treatment of adolescent-onset schizophrenia. And also, the last two sections of this presentation, I will cover the schizophrenia spectrum. The psychotic spectrum is potentially important for early diagnosis and management of psychotic disorders, as well as early detection of relapse. Delay in treatment of the first episode is a major problem and is associated with a poor outcome. And that's the reason I have left intentionally those last two sections to the end. Now, to start, what is psychosis? Psychosis, there are many definitions of psychosis. First of all, psychiatrically, it can be defined as a gross impairment in reality testing, a loss of contact with reality, as an inability to distinguish what is real from what is not real, also as a loss of ego boundaries. Also, psychosis as a legal definition, as insane, when someone who committed a crime could not distinguish between right and wrong at the time the crime was committed. Also a legal term, non-compos mentis, which means not of sound mind, memory, or understanding. Also in street language, in lay terms, pejorative. The psychotic patient may be identified as crazy, mad, lunatic, maniac. So we have all heard those terms interchangeably in the common language. And as far as we are concerned, most of the psychiatrists in DSM-4, revised edition, psychosis is defined by the presence of delusions, any prominent hallucinations, disorganized behavior, or catatonic behavior. This slide is an attempt at differential diagnosis for psychotic symptoms in childhood and adolescence. First of all, we should not assume that psychosis is synonymous with schizophrenia. So there are a lot of other conditions that can account for psychosis. Psychotic symptoms also develop as a consequence of a general medical condition, for example, a frontal lobe injury, thyroid disease, substance abuse, prescription drugs, poisoning like by anticholinergics, carbon monoxide, heavy metals. Also, a mood disorder with psychotic features may present with psychosis. Also, OCD, obsessive compulsive disorder. Although OCD does not typically feature psychotic symptoms, the patients may appear sometimes as bizarre, and if we don't have enough history, we may take them as being schizophrenic or fully psychotic. Also, the personality disorders, paranoid personality disorder, schizoid and schizotypal personality disorder, they can present psychotic features. Also, dissociative disorders, those trance-like states, fugue, they can mimic schizophrenia or other psychotic disorders. Also, we have the multidimensional impairment, brief psychotic symptoms, the poor affect regulation, a patient with difficulty with attention and impulse control, maybe in the prodromal phase of schizophrenia, so those patients may be psychotic, may be easily confused with schizophrenia. And as far as we are concerned in this presentation, to be included in this differential diagnosis, a childhood onset schizophrenia spectrum. What are the DSM-4 criteria for childhood onset schizophrenia? I'd like to emphasize that the criteria is the same as for adult, except criteria B. So the first criterion A, there must be at least 2 symptoms for 1 month for a period of 1 month, or less if the patient is being treated. The 2 symptoms may include delusions, hallucinations, disorganized speech and behavior, negative symptoms, or criterion A may be satisfied with only 1 symptom. If there's a bizarre delusion, or if the patient is hearing voices, the voice make a warning commentary on the patient's thoughts or behavior, or if the patient complains of hearing 2 voices in a conversation. So, criteria B, failure to achieve expected interpersonal or academic achievement. Like, for example, a 6-year-old is not making friends, is not interested in interpersonal relationships, is failing his classes. So that's a failure to achieve expected. However, for adult, the criterion B is failure to attain the prior level of functioning. And for child is expected, failure to achieve expected. So that's the main difference between childhood and adult. And also there's a 6-month criteria that are continuous, 6-month duration. And during those 6 months, there must be a 1 month of full phase, of active phase psychotic symptoms. So that can be satisfied by criterion 1A. Also, mood symptoms, if present, are brief relative to other symptoms. In other words, schizoaffective disorder or major depression or with psychotic features are ruled out. Criterion E, the psychosis cannot be secondary to substance abuse or a medical condition. And if there's a comorbid autistic spectrum disorder or pervasive developmental disorder, we need hallucinations and delusions for 1 month. Negative symptoms, they like adult schizophrenia. They are specifically characterized by DSM-4 as affective flattening, flat affect, blunted affect, which is less severe than flat affect. Thought blocking, the train of thought suddenly stops. For example, in the middle of a conversation, patient stops, no longer have the train of thought. Avolition, poverty of movement. There's restriction in initiation and production of goal-directed behavior. Anhedonia. These negative symptoms can also be found in major depression. It means inability to experience pleasure. Abulia, which is poverty of motivation. For example, the patient has restriction of will or motivation, often characterized by his or her inability to make decisions or set goals. And also asociality, poverty of socialization. Restriction of social interactions with the little interest in developing relationships. In this slide, I try to compare, to show the differences between childhood onset schizophrenia and adult onset schizophrenia. Compared to adult onset schizophrenia, childhood onset schizophrenia is harder to treat. It has a worse prognosis. It has less robust responses to antipsychotic medication, and this is more so in children. And also there's a higher rate of schizophrenia spectrum disorder reported in the families of childhood onset schizophrenia per bands, 33% versus 10 to 20% in adults. And also childhood onset schizophrenia have, in general, more chromosomal abnormalities. And also this is prevalent, this is widespread in the literature. There's a characteristic progressive reduction in the volume of gray matter during adolescence. On the right, we have 3-dimensional scans of high-resolution MRIs of 2 groups of subjects. We have normal adolescents, and we have schizophrenic subjects. Interestingly, in the temporal cortices here, and sorry, in the parietal cortices and temporal cortices, the red areas represent areas of severe gray matter loss. So this loss can take place at a rate of up to 5% annually. Also, interestingly, the frontal lobes are preserved, just like the normal adolescents, you know. So the gray matter loss is more severe in the parietal cortex here, and in the temporal cortex. And the blue area in the frontal lobes is relatively preserved. Also, interestingly, in normal adolescents, there's some dynamic gray matter loss taking place in the in the parietal cortex here. This area, you see, is a light blue area. So there's some change taking place, but the rate is much lower compared to schizophrenic patients. Here we have some similarities with adult onset schizophrenia in terms of physiology. There's greater smooth pursuit eye tracking abnormalities compared to the normal population. In terms of brain structure, we have the same structural brain abnormalities as in adult onset schizophrenia. We have enlarged ventricles, reduced gray matter and cortical thinning. In terms of brain metabolism, we have abnormal energy metabolism and phospholipid turnover. And it appears as well that the schizophrenia susceptibility genes are comparable. There is an association between abnormal genetic encoding of this binding and schizophrenia. And interestingly, both adult onset schizophrenia and child onset schizophrenia are most responsive to clozapine. The next slide, the objective of this slide is to describe the premorbid state of the early onset schizophrenia. In a study by Muratori, an associate at the University of Pisa in Italy, 23 early onset schizophrenia patients were compared to a group of normal subjects, I did not include here, and a group of anorexic patients. During the premorbid state, here, first of all, I wanted to say that the CBCL, the Child Behavioral Checklist, was given to the mothers of early onset schizophrenia patients, respectively. And so what Muratori found was, during the premorbid phase, age 4 to 11, early onset schizophrenia patients, they show significantly higher scores on some scales, such as there are more social problems, more thought problems, more attention problems, and more school problems in the premorbid phase of EOS patients. Also, during the premorbid stage, early onset schizophrenia patients, 1/3 of them had a high total problem score on the CBCL. And Muratori found as well that during ages 2 to 3, there was an internalizing profile on the CBCL that became worse in subsequent periods. The objective of this slide is to show the overlap with autistic spectrum disorders. As we all know, child onset schizophrenia is a severe form of adult onset schizophrenia with a high rate of premorbid developmental abnormalities. Early symptoms of pervasive developmental disorders have been described in at least 7 studies of childhood onset schizophrenia. And here, the author, Alexandra Spohn, she has regrouped together 7 studies that describe premorbid developmental abnormalities. One of the studies that dated to 1971 by Colvin. 87% of COS patients, they had social abnormalities. 49% had major milestone delay, and 46% had speech delay. In another study by Asano and Ben Meyer in 1988 at UCLA, some patients had very poor PAS score. PAS is the premorbid adjustment scale score. They also had, some of them had poor premorbid social functioning. I'm not going to go to all the studies, but in a study here by Green in 1990 at New York University, there were 38 subjects. The age of onset of child-onset schizophrenia was before age 12. There was poor premorbid intellectual functioning in 79% of the subjects. Also, there was language delay disorders, 42%. 36% had motor impairment. The author found in 50% of the patients social impairment. There was PDD features in 36%, infantile autism and Asperger's syndrome in 13%, and transient motor PDD features in 30%. So basically, the purpose of this slide is to show that early onset schizophrenia patients, they have a high rate of developmental abnormalities that can easily overlap with autistic spectrum disorders. The next slide, pervasive developmental disorder and child onset schizophrenia, comorbid disorder, or a phenotypic variant of a very early onset illness. In this study, Spawn and associates from the previous slide, she compared evidence for premorbid PDD as a non-specific manifestation of impaired neurodevelopment seen in schizophrenia, or as an independent risk factor for child-onset schizophrenia. Child-onset schizophrenia subjects with and without PDD were compared with respect to neurobiological, neuropsychological, and clinical measures. In the study, the diagnosis of autism was made based on DSM-4 criteria. And the candidate genes for autism were examined using the transmission disequilibrium test, TDT. So here we have the result of the study. Spawn and associates found that 25% of child-onset schizophrenia patients, they had PDD. They met criteria for pervasive developmental disorder. One of them had met criteria for autism, another one for Asperger, and 16 of the patients met criteria for PDD-NOS. And also what she found was that the PDD group did not differ from the rest of the COS group in terms of the age of onset, IQ, medication response, outcome, family history, and MRI findings. None of the candidate genes for autism were found to be associated with either the COS sample or the COS with PDD sample. So the gene for autism, they're not a precursor for child-onset schizophrenia. And interestingly, in the PDD sample, if she found more premorbid social impairment, more language delay, and more motor problems. There's also a finding in the study in the PDD group, 17% of the PDD group had siblings with autism, and the author could not explain why. So it was something anecdotal. There's no reason, there's no explanation. This slide is about similarities between schizotypy and child-onset schizophrenia. So what is schizotypy? Schizotypy has been coined by the British psychologist Gordon Claridge after examining unusual experiences in the general population and the clustering of symptoms in diagnosed schizophrenia. Schizotypy can be broken down into 4 factors. The first factor, he called it unusual experiences, hallucination, magical or superstitious beliefs. The second factor, cognitive disorganization. The patient, for example, the subject or the patient has derailed thoughts. The third factor, introverted anhedonia. The person is introverted, emotionally flat, and asocial. Also, the last factor, it's a fancy factor, it's a fancy name, impulsive nonconformity. Patient is unstable with regard to rules. In the literature, the schizotypy is considered similar to schizophrenia prodrome or clinical high-risk state. In the UCLA follow-up study, Asano in 2005 assessed 12 children with schizophrenia 1 to 7 years following initial project intake. This is a result. 17% of the schizophrenia sample deteriorate, and 28% had a good outcome. That means those patients, they no longer met the schizophrenia criteria at 3-year follow-up. And for the schizo-CP sample, the results are the following. At 3-year follow-up, 25% of the schizo-TP sample developed schizophrenia of schizoaffective disorder. 50% of them remain schizotypal. 10% degenerate into bipolar, and another 10% degenerate into other disorders. We don't know what they were. I think in the results for the schizo-CP sample, these results support the hypothesis that schizo-CP is a risk factor or a precursor state for more severe schizophrenia spectrum disorders. So it seems to be supportive of that, according to this study. Etiology. What causes schizophrenia is a question that has occupied the mind of every psychiatric researcher and theoretician for over half a century. I searched the literature. The causes and the nature of schizophrenia remain obscure. We don't have a real cause. Like, schizophrenia is not characterized by any reproducible neurochemical abnormalities. However, there are some structural and functional abnormalities that have been observed in the brains of children and adolescents with schizophrenia, such as enlarged cerebral ventricles. This is a consistent finding. And also atrophy of cortical layers, which is relatively consistent. Also, many studies have described reduced volume of the basal ganglia, and also reduced size of the temporal lobes, frontal lobes, and prefrontal cortex. Now, we don't know the cause of schizophrenia, but there are a lot of hypotheses that try to postulate the reason for schizophrenia into being. There are some susceptibility theories. The first one is the genetic hypothesis, the genetic theory, which confers 50 to 70% of the risk of schizophrenia. According to this theory, to this hypothesis, schizophrenia runs into families, and the risk increases with closer genetic associations. For example, an individual with 2 parents with schizophrenia has a higher risk of getting schizophrenia than the general population. And his risk of getting schizophrenia is increased compared to someone with an identical twin with schizophrenia. And his risk also is increased compared to somebody with a fraternal twin, and compared with someone that belongs to a family with a child from a schizophrenic parent that was adopted. And that's greater than the general population. What are the genes that have been implicated in schizophrenia? The MTHFR, the methylene tetrahydrofolate gene, has been consistently described in the literature through its impact on DNA methylation. The catechol or methyltransferase gene also has been mentioned. The disbinding gene has also been mentioned. The NRGI, neuregulin 1 gene, to its role in the expression of glutamate receptors, also has been implicated in the pathogenesis of schizophrenia. Now we have another susceptibility theory, the so-called monoamine hypothesis. Monoamine includes both dopamine and serotonin. It is postulated that hyperdopaminergic state in the mesolimbic pathway is responsible for the positive symptoms. As a matter of fact, the desired antipsychotic effects of all those medications, Haldol, not Abilify, like Risperdal, all those antipsychotic medications, they're taking place. Their desired effect take place in the mesolimbic pathway. So, also, hypodopaminergic state in the mesocortical pathway is responsible for negative symptoms. The mesocortical pathway projects to the prefrontal cortex, which is involved with higher cognitive functioning, such as working memory, attention, motivation, emotional expression, and filtering stimuli. Also, another theory, excess of serotonin induces psychotic symptoms. Supporting this hypothesis is the finding that hallucinogens acting as partial serotonin 2A receptor agonists, such as LSD, can produce florid psychotic symptoms. Also, blocking serotonin 2A receptors purportedly has the added benefit of improving negative symptoms, reducing EPS, and reducing prolactin increases. Second-generation antipsychotics, except aripiprazole, generally block serotonin 2A receptors more than T2 receptors. Aripiprazole, Abilify, is a partial agonist of dopamine 2 receptors, as well as a partial agonist of serotonin 1A receptor. And just like the other second-generation antipsychotics, aripiprazole also is an antagonist of serotonin 2A receptors. Other susceptibility theories, neurodevelopmental hypothesis. It has been postulated that perinatal complications such as hypoxia, forceps delivery, have been associated with increased risk, earlier age of onset, negative symptoms, and proven prognosis of schizophrenia. Nutritional deficiencies in pregnant mothers also have been implicated. Lack of calories, lack of vitamin D, lack of folic acid during pregnancy can predispose a pregnant woman to give birth to early onset schizophrenic child. Also, low birth weight and a shortened gestational period. Also, errors in neuronal cell migration in utero. There's also the so-called environmental hypothesis, toxic chemicals in the environment to its effect on brain damage. And now we have those controversial theories, those controversial discounted hypotheses, express emotion theory. Express emotion includes critical comments, hostility, emotional over-involvement made by caregivers of patients with schizophrenia. Interestingly, the levels of each component and their relative contributions vary across cultures. According to Gelder and Stein and Wilkinson, they are most predictive of relapse. And also, there's a so-called double-blind theory, which proposed that schizophrenia was caused by repeated contradictory patterns of interaction during early developmental years by a schizophrenogenic parent. For example, a parent tells a child to play outside while it is raining, but not to come back wet. This is no longer recognized as a valid hypothesis. Epidemiology, child-onset schizophrenia is extremely rare in children younger than 6 years old, but the frequency steadily increases in those older than 11 years. It is divided into very early onset schizophrenia before the age of 13 years old, and early onset schizophrenia after the age of 13 years old. In various studies, males outnumber females by up to 2.5 times. Among patients with a very, very early age of onset, males outnumber females even more. The age of onset of child-onset schizophrenia is not different in boys and girls before puberty. In adolescence, COS develops approximately 5 years earlier in boys. Childhood-onset schizophrenia is more common in less educated and less professionally successful families. But as in adult-onset schizophrenia, the low social status may be the result of mental illness in the parents, which explains the downward drift theory. What is the treatment of child-onset schizophrenia? In a 6-week study, double-blind, randomized controlled trial by Kumra in 1996, clozaril was found to be superior to haloperidol. Clozapine led to greater improvement in symptoms, but was associated with neutropenia and seizures. In another double-blind randomized controlled trial by Shaw in 2006, it's an 8-week study with 25 patients, clozapine was found to be superior to Zyprexa, olanzapine. In that study, clozapine led to greater improvement in symptoms, in particular negative symptoms. However, it was associated with lipid abnormalities and seizures. So clozapine tends to decrease the seizure threshold. Effective treatment for adolescent onset schizophrenia. It is more similar to adult onset schizophrenia than child onset schizophrenia. Olanzapine is superior to placebo. Risperidone has been found to be effective. I will describe this study in more detail in the subsequent slide. Abilify also has been found to be effective. I will also cover that in greater detail in upcoming slides. In the treatment of early onset schizophrenia spectrum study, olanzapine, risperidone, and molindrone were found to be equally effective for childhood and adolescent onset schizophrenia. As I mentioned earlier, in a study by Haas, published in the British Journal of Psychiatry in 2009, it was an 8-week double-blind randomized control study. Subjects, patients with schizophrenia, adolescent schizophrenia, ages 13 to 17, they were randomized to either regimen A or regimen B. Regimen A consisted of risperidone with a dose range of 1.5 to 6 milligram daily, and regimen B consisted of risperidone, 0.15 milligram to 0.6 milligram daily. What Haas and associates found, they found that in regimen A, the PONS score were significantly reduced compared to regimen B. And the adverse effects in regimen A was for 74% and 65% regimen B. And the treatment associated with gain was 3.2 kilogram in regimen A and 1.7 kilogram in regimen B. The author concluded that regimen A was associated with greater reduction in positive and negative syndrome scale. In a study by Feinlein and associate in 2008, patients with schizophrenia ages 13 to 17 were randomized to either placebo, Abilify 10 milligram, or Abilify 30 milligram. The results of that study was the following. Both 10 milligram daily and 30 milligram daily doses of Abilify, they had superior efficacy to placebo in terms of reduction in total positive and negative syndrome scores. Both doses were associated with extrapyramidal symptoms, somnolence, and tremor. And in general, Abilify was well tolerated. There was no difference in changes in prolactin or weight gain compared to placebo. In a study by Sikish and Associates in 2008, treatment of early onset schizophrenia spectrum disorder, 116 patients ages 18 to 19 during 8 weeks, they were randomized to either olanzapine or risperidone or molindone, which is the first generation antipsychotic. The dose range for Zyprexa was 2.5 to 20 with a mean dose of 11.4. And the PANSS score reduction was 34%. In the risperidone treatment group, the dose range was 0.5 to 6 with a mean dose of 2.8. And the PANSS score reduction was 46%. And in the last treatment group, molindone with benztropine, the dose range was 10 to 140 milligram daily with a mean dose range of 59.9. There was 50% reduction in PANSS score. The author found no significant difference between the PANSS score reduction among the treatment groups. So the author concluded that olanzapine and risperidone, which are second generation atypical antipsychotics, they are not superior to first generation antipsychotic. I know that second generation antipsychotics, they are the standard of treatment nowadays. But in that study and in other studies, second generation antipsychotic were not found to be superior to first generation antipsychotic. And also they were associated with some adverse effects such as weight gain, increased fasting cholesterol, increased LDLs, increased insulin, and increased liver transaminase. For the risperidone group, it was constipation, and it seems that for the first generation antipsychotic group, molindone and benztropine, the only mentioned adverse effect was akathisia. This graph illustrates the development of first episode psychosis. I borrowed this graph from a conference I attended in Munich. This graph is from the psychiatric department at the University of Cologne in Germany. This graph is divided into two sections. In the first section here, I'm trying to get the cursor. This is considered the initial prodromal phase of psychosis. As we can see, as the curve slopes upward, there's more social decline and more neurobiological changes taking place. Around here, we have the high-risk state, with that heralds psychotic symptoms. Patients start to hear voices, become delusional. So this is considered high risk, and usually patients seek treatment in that stage, at that point. And some patients, they go on, the curve slopes upward more, and for some reason, I don't know, the author described here this point as very unfavorable. I don't know if because the patient is no longer responsive to treatment or if psychosis got worse. So, but the author from the University of Cologne described this point as unfavorable. I think the second graph is more illustrative, is more chronological. It shows the development of psychosis over time, with arrows indicating points of change noted by the patient or informants. In the first arrow here, the patient first notices some changes in self. In the second arrow, the family or friends first notice some change in patient. In the third arrow, patient first notices psychotic symptoms in self. In the fourth arrow, family or friends first notice psychotic symptoms in patients. And here at the maximum, in the fifth arrow, this is usually where the first psychotic intervention takes place, according to this graph. So, before the first episode of psychosis. So what is the schizophrenia prodrome? It consists of non-specific symptoms. Here are included, we have social isolation, anxiety, deterioration in whole function at school, attenuated or brief psychotic symptoms, illusions, overvalued ideas, suspiciousness, non-specific symptoms such as anxiety, depression, irritability, apathy, withdrawal, lack of initiative, and sleep disturbances. And the estimated length of the prodrome is around 4 years. Here, it is said that prodromal patients have a 30 to 40% risk of developing psychosis in approximately 2 years. What are the interventions to try to prevent the first episode of psychosis? Antipsychotics may have some efficacy in preventing psychosis onset, but they are associated with side effects. Zyprexa is associated with weight gain, Abilify with akathisia, and Risperdal with prolactin increases. Psychological treatments such as CBT are well tolerated, but may only be effective for the duration of administration. Also, new studies, new research, new protective strategies such as omega fatty acids, which show promises, but they require more replication. And at the end of this presentation, I wanted to include a case just to stimulate your thoughts on early onset schizophrenia. 13-year-old male was seen in the clinic due to walking out of class, complaining somebody after him, and ripping off his clothes when upset. He shouts in the class without any reason. He laughs and talks to himself. He has tendency to rub the skin off his knuckles until it bleeds. He stated that he rubbed the skin off his knuckles because it was dark. So I wanted your thoughts on this vignette. So what do you think it is? Any thoughts? Is the patient schizophrenic? Is he just psychotic? Does he have a personality disorder? Is he in what they call a dissociative state? Is he hyperthyroid? So how would you manage this patient? What would be the first step? Yeah, get the clinical history. I think I'll get a history. I would get a history, family history, past treatment. We could order some labs, TSH, a blood count, a metabolic profile, RPR, syphilis screen, RPR. And depending, we may also order a CAT scan, but that's very expensive. So, and that's the end of this presentation.